Okay, most of you know our next speaker. Her talk is titled The Rarest of the Rare, What Our Genotype-Phenotype Study Taught Us About Rare Symptoms in CTNNB1. Please welcome Nina Žakelj, resident in Pediatric Neurology Department from the University of Medical Center of Ljubljana.
I think this works. Hi, I'm having some technical difficulties. Title. Oh, okay. This is not what my slide was supposed to look like. I'm sorry. Anyway, my name is Nina Žakelj. I'm a neurology resident from Ljubljana. Most of you probably remember me from the genotype-phenotype correlations interviews that we did a few years ago. Some of you I was fortunate enough to meet in Madrid last year, and I'm hoping to meet the rest of you today. I'm always happy when I'm invited to speak on the topic. I'm happy to be a small part of the community. And today I'm going to be talking about the rare symptoms in CTNNB1 syndrome, specifically on what we learned about them during our genotype-phenotype study. So I'm not going to bore you with what CTNNB1 syndrome is. You guys know this better than me. The clinical hallmarks of the disease are developmental delay with muscle tone abnormalities, intellectual disabilities, speech delay, and dysmorphic features. Last year in Madrid, my talk focused more on these clinical hallmarks, and today I'll be talking about rare symptoms and symptoms that are actually common but rarely talked about. CTNNB1 syndrome was first described in 2012. I personally first found out about it in 2020 when I joined the research team. And since then, there's been a surge of new information on the topic. New articles, new case reports, new genotype-phenotype correlations. And with every article, we get new invaluable data on what CTNNB1 syndrome and its phenotype actually are. We tried to add a piece to the puzzle by doing our own genotype-phenotype correlation study, which started in March of 2021 and concluded by the end of 2022. Parents all over the world were invited to participate. They met me online, where I took them through a structured interview consisting of over 500 questions regarding their children's current medical status, functional status, and relevant medical history, as well as a bunch of standardized tests that I'm not going to mention today. In total, I interviewed 127 parents who were residents of 20 different countries, and this is what I learned about the rare symptoms. The first symptom I'm going to talk about are motor stereotypies. These are rhythmic, fixed, involuntary, purposeless movements that are predictable in pattern and location on the body. They're associated with periods of engrossment, excitement, stress, fatigue, or boredom, so they can accompany either positive or negative emotions. They stop when a person is distracted, and they usually begin in early infancy and can persist into adulthood. They're divided into primary and secondary motor stereotypies. Primary are found in healthy children, approximately 20% have them, and they're subdivided into 3 separate entities. So common behaviors such as rocking, head banging, finger tapping, hair twirling, also thumb sucking. The other entity is head nodding, and the third one is complex motor behaviors such as arm flapping or arm waving. Secondary motor stereotypies are present in children who have an additional diagnosis, such as autism spectrum disorder, cognitive disability, psychiatric conditions, neurodegenerative and metabolic disorders. We found that almost 40% of children exhibited motor stereotypies, which is not rare, but we usually talk about dystonia, we talk about spasticity, we talk about muscle tone problems, and we rarely mention stereotypies. But I'm sure you're not surprised that they're so common, as a lot of the children exhibit issues related to autism spectrum disorder, intellectual disability, and behavioral issues as well, such as aggression and autoaggression. And these states are usually the ones where motor stereotypies are present as well. The second topic I'm going to cover is fever. It's a rare disorder of the retinal vessel development. For normal vision, a healthy retina is key, and in this disorder, the problem lies in the vascularization of the peripheral retina. So if the retina is not getting enough blood, it's not going to function properly. And in fever, peripheral blood vessels do not get formed. Our body tries to help us, promoting a process called neoangiogenesis, which leads to basically creating new blood vessels on the periphery of the retina. But the problem is that these vessels are not functional. So they're leaky, they cause hemorrhages, and they can lead to retinal ischemia and detachment. Clinical features of fever are visual impairments to one or both eyes, and in most severe cases, they can lead to complete blindness. We found that almost 10% of the children in our cohort exhibited fever and were also tested for it and diagnosed, but we found no genotype-phenotype correlations that would explain the connections. If you look at the last row, the visual function classification system, we found that 1.6% of the children who took our interview were blind, and all of them were blind due to fever. Another interesting topic are sleep disturbances. They're actually very often reported, but rarely described in detail. It's very hard to systematically classify what kinds of sleep disturbances children with CTNNB1 syndrome have. What parents do report are trouble falling asleep, trouble maintaining sleep, often waking up during the night with laughing or crying fits. We try to assess that using two questionnaires. The PSQ, so Pediatric Sleep Questionnaire, which is actually intended for children with sleep disordered breathing, and BISC, which is a sleep questionnaire intended to assess sleep quality in children. What we found is that maybe these two are not the most appropriate ones to assess that in CTNNB1 kids. I honestly have no idea which others we could use to make this assessment better. But we did find that more than 50% of parents reported very serious sleeping problems in their children, and all of those children were taking sleeping medication to help them sleep. And almost 40% of parents reported at least a small problem with their children sleeping. Another interesting topic is hereditary hyperexplexia. It's a neurologic disorder which is manifested by an exaggerated startle response, general muscle rigidity, and prominent nocturnal myoclonus. It's an excessive startle response to tactile, visual, and auditory stimuli that does not habituate. It's present from birth, and in contrast to a normal startle response, excessive startle leads to stiffening, which causes risk of falls, injury, and apneas. It's important to note that consciousness is unaltered during these episodes and that this is not a seizure activity. Hereditary hyperexplexia is by definition associated with mutations in 3 specific genes. None of them are CTNNB1 gene, but I found an interesting review of hyperexplexia in other syndromes, which also mentioned CTNNB1, and they reported that true hyperexplexia with body stiffening and falls is rare in CTNNB1 syndrome, but excessive startle reflex is actually quite common. And that's in line with what we found as well. We found that 91% of children exhibited excessive startle response in the past, and 88% of the children exhibited excessive startle response at the time of our interviews as well. I found 2 articles. Again, I'm sorry for the letters overlapping. It did not look like this on my computer. Anyway, this interesting article basically examined 12 patients with CTNNB1 syndrome and found that all 12 of them had an exaggerated startle response, and 8 of them also fell due to this exaggerated startle response, which means that there's some component of stiffness and rigidity as well. They proposed that hyperexplexia is maybe not the best term to use in these children because it's not hereditary, as I said before, but maybe atypic or syndromic atypic hyperexplexia would be the better term to use in CTNNB1. Another study is currently ongoing in France, which is planning to systematically assess hyperexplexia in these patients, and I'm looking forward to read about their results. The last few topics that I'm going to mention are just going to be skimmed through because we're having interesting lectures on these topics following mine. So take this just as a segue into the next presentations. Corpus callosum is the largest white matter structure in the brain, and it consists of commissural nerve fibers, which connect different brain structures and regions between the left and the right hemisphere. Usually the abnormalities that we see in corpus callosum are agenesis, so corpus callosum that does not get formed, hypoplasia, so loss of volume, and hypoplasia with dysplasia. Clinical features vary. Patients can be asymptomatic or they can have symptoms of autism spectrum disorders, seizures, poor motor coordination, trouble with depth perception, behavioral and intellectual disabilities. Fun fact, Kim Peeks, who's seen on this picture, he was the inspiration for Rain Man, and he was born without a corpus callosum, so with a corpus callosum agenesis. He had the perfect memory. He was able to read both pages of the book at the same time, but he was unable to tie his own shoes or button his own buttons because of very poor motor coordination. We analyzed MRI reports of 118 patients. Most had normal MRI. About 29% had abnormal MRI readings. It's important to note here that we only analyzed the results, not the actual raw images. And we found that 5 patients had corpus callosum abnormalities, and additional 4 patients had corpus callosum volume loss. It would be very interesting to study these patients further with standardized MRI imaging and digital tractography as well to determine the extent of corpus callosum abnormalities in them. Tethered cord is not something that we systematically assessed in our cohort. It's a group of neurological disorders which involve the pulling of a spinal cord at the base of the spinal canal due to abnormal scar, fibrous, or fatty tissue, which restricts its movements. Usually the parents and doctors first notice lesions, hairy patches, dimples, fatty tumors on the lower back. And with time, it can lead to foot and spinal deformities, leg muscle weakness, scoliosis, lower back pain, and urinary incontinence. As I said, we didn't systematically ask for tethered cord in our interview, but a lot of parents actually reported it. So this is absolutely something that needs to be studied in the future. We asked about heart abnormalities. 16 children from our cohort exhibited heart abnormalities. That's 12% of the children. 4 had a tricuspid valve regurgitation, which means that the blood is flowing back from the right ventricle to the right atrium. 1 of them was surgically treated. 4 had atrial septal defects, which means that they had an abnormal communication between the right and the left atrium, causing a right to left shunt. 3 had ventricular septal defects. 7 had a patent foramen ovale, which is basically another abnormal communication between the atria that usually closes after birth. 1 had a patent ductus arteriosus, which is an abnormal connection between the aorta and the pulmonary artery, and also usually closes after birth. And 1 patient had an absent pulmonary valve. The last topic I'm going to mention are seizures. Seizures are bursts of uncontrolled electrical activity between neurons that cause temporary abnormalities in muscle tone or movement, behavior, sensations, or states of awareness. So they can either be convulsive or non-convulsive. By definition, they're either focal or generalized, and we have more entities in the generalized seizure group, such as tonic-clonic seizures, tonic seizures, clonic seizures, atonic seizures, and absent seizures. In our cohort, 9 children experienced seizures in the past. That's about 7% of children. 5 of them were treated with anticonvulsive medications, and 5 children were still experiencing seizures at the time of the interview, which is 4% of the children, and only 1 of them hasn't been treated with anti-epileptic medications. In literature, reported seizure activity is low. It's estimated to be at around 11%, and most patients have a self-limiting epilepsy of childhood or febrile seizures. So that concludes my topic of rare symptoms. I'm inviting you to stay and listen to the other presentations, which will cover corpus callosum, abnormalities, seizures, heart defects, and so on. I'd like to thank my team, all of the parents that responded to our call for interviews, And everybody who's participating in the natural history study, I'm sure we get a lot of invaluable data today and yesterday as well. So thank you so much.